Junior Family Broadcast Studio, and we are so grateful to have you join us today. This is the day that we dedicate to trying to catch up on all the many and wonderful questions that you send to us, but I have help. To my left, I have Dr. Jessica Callender-Rich. She, as you know, is a general in geriatric medicine and a doctor and a national member of the Coronavirus Commission for Safety and Quality in Nursing Homes, and we hope to get an update from her. And to my right, the very familiar Dr. Dana Hawkinson.
Hi.
Welcome.
Hi.
Let's do how we always do. Let's start with the numbers.
The numbers. The numbers are about the same as yesterday. We have really been in the range of 18 to 22 for the last 5 or 7 days, I believe, which is a good thing. We certainly would prefer lower, but absolutely do not want higher. 7 of those patients are in the ICU and 3 are on the ventilator. So we did have some admissions and discharges in the last 24 hours, so our numbers are about stable. However, from what we know around the city, really overall, the number of COVID patients in the city compared to, say, 3 or 4 weeks ago is up quite a bit. So.
All right. We're going to get to you and ask some questions, so
Okay.
don't go anywhere. All right?
I won't. I'm ready.
So before we go to the questions, can you give us an update on your work with the National Committee?
Sure. So we have continued to have meetings and homework in between those meetings related to just evaluating where we are and where we're going. And they are going to be opening up a new public forum for people to give input. And I think we're all really excited about that.
Well, we do know we have questions for you, which is one of the reasons why I gave you a hot ring yesterday and said, hey, can you join us? Because we have some really good questions, again, from the community. Are there any media on the line that have pressing questions about COVID-19 today? Well, here to help us in studio is the voice of Bob Hallinan, and Michelle, of course, is signing for us this morning. Bob, do we have questions from the community?
We do. Brianna wants to know, can someone please address post-acute care for COVID patients in Kansas? Our memory care patients are at great risk for significant deterioration from limiting visitors, and KDHE requires negative testing for admission. What can we do?
So this is really a question we've sort of monitored and followed really across the whole country and of course locally. There was initially some guidance that required multiple tests before folks could be admitted from the hospital to the post-acute setting, but that has since been revised by KDHE. And in fact, I'm told there are several counties that are currently still in the process of updating those guidelines. But currently in the Kansas City metro, they are already updated, and the state and counties are in alignment to not require negative testing prior to admission to the post-acute space. That said, those people that are new admissions to the post-acute space, whether it's in memory care or in skilled nursing or any post-acute space that may be, are required to have a 14-day isolation or insulation period where we really focus on ensuring that if they are going to crop up with symptoms, we can keep them away from other residents and contain any COVID that may be new. There's some, to your point, really about the risk to those people of being without the therapy services that they need and without the other supports. We've seen some really creative things happen in the facilities once they're admitted to allow those procedures to occur perhaps in the room or in a way that allows them to remain under their protected status.
I know that some questions have also centered around the fear that if grandma and grandpa are not getting visitation from family, that they deteriorate at a faster rate maybe than other people. There's a big concern around that. Is it true? Is there difference between my being isolated at home and grandma and grandpa?
It's true. I mean, it really is. So what we are seeing is that those older adults or vulnerable adults, in fact, who are more isolated, even in general times, we know that isolated older adults are more likely to have physical and cognitive decline. And we have seen on a national scale that this has happened. And that is why CMS has come out really stating that it was critical that we clamped everything down in the way that we did, because we needed to get a handle on what to do moving forward. But now it's critical to get our numbers in each community under control such that we can then turn around and reopen and allow more of those, frankly, essential visitors and family members to come and see their loved ones.
All right. Do you have another one?
Judy wants to know when a vaccine is available. Okay. Look into your crystal ball here. Is it going to be like an annual flu shot where you have to do that every year? Or is it going to be a one-time vaccine with maybe a booster down the road?
Yeah.
Any thoughts?
Yeah, I mean, at this point, our best guess and our best prediction is that it'll probably be a yearly thing, similar to influenza. Will there be boosters? Will there be other things you need in between the boosters? It's really difficult to say. A lot of people do anticipate needing more than one vaccine for this virus. So there are still a lot of options out there. We know that the government and the NIH have partnered with several different companies to produce vaccines so that when they are proven safe and efficacious, we will have those. But it's anticipated it'll probably be more like needing a yearly vaccine. But also the question is, are there going to be 2 or 3 different kinds or more vaccines that we're going to need? So there are still a lot of questions out there. There are a lot of companies doing trials and looking for vaccines. But until we get there, we don't know for sure. But we anticipate it'll probably be more like a yearly thing. Again, we just don't know how long immunity lasts against coronavirus in general and against SARS-CoV-2 specifically. So we know that you can be infected with the same coronavirus, the common cough and cold coronavirus that we know of, in 3, 6, 9 months and still have mild to no symptoms. So we still don't know all about immunity, and that does not help us when we are trying to create a vaccine. But we do have a lot of companies out there trying to produce vaccines. So more than likely, we will probably need at least a yearly booster. And potentially, there may be 2 or 3 different vaccines that we need to get.
All right. Allie asked a question earlier in the week that I'd like to have both of you weigh in on because there are some older adults that will be in the classroom. She wants to know, how are we going to keep teachers and students safe?
Yeah, I think I'll start with that, obviously. So I think a lot of people agree students need to be back in school for one reason or another. They need that directed learning. They need that structure. School lunches are important. Schools can provide safe places. How do we do that? How do we go about doing that? I think it really boils down to the community that you're in, the school district and the school. We know that we can reduce risk as much as possible of spreading from children to adults and adults back to children. There is some indirect evidence suggesting that children maybe don't spread it as well as adults, but from a few viral studies, we know that they can produce the same amount of viral load as adults. So that's really unclear as far as that goes. We know that in general, children spread viruses such as cough, colds, and gastrointestinal bugs, certainly more or the same as adults. So that's important to note. But I think there are measures that can be put in place. We know the CDC has issued guidelines, guidance. They're not rules and not laws to do, but guidance for school districts and schools to follow to help mitigate that risk. Most importantly is going to be distancing as much as possible. Face masks are going to be important. I know that my nephew is 5 and he's going to have to wear a face mask to his daycare. So it is definitely more difficult for little kids. We also understand that little kids, it's going to be more difficult to socially or physically distance. But as you get into the older kids, if you can have desks that are further apart from people, teachers, wearing masks, the school-age kids that can wear masks if possible. Luckily, so far from what we've seen from Asia, I believe South Korea and Japan, when they have gone back to school, I don't think we've seen any rise in cases from those specifically. So there are things you can do to mitigate and reduce the risk as much as possible.
And I'll just add, I think for our teachers that are out there, and I know a huge part of our educational workforce falls into what I consider the older adult category. For each of those people, I think it's important to just weigh, what other medical comorbidities that person has in order for them to understand their personal risk. And then really just, all the things that Dr. Hawkinson said. Many times the teacher can remain at the chalkboard, or they're not called that anymore, but whiteboard,
Yeah.
Thank you. Smartboard, whatever it may be. But allowing that teacher to really feel safe, I think, is a critical piece of really beginning our education system again. And so the things that can be put into place related to masking and distancing are critical. The other thing I think that's good is probably cohorting in some way so that the teachers know to whom they're exposed. And I will say we need to help those teachers out. And so that means really helping our kids at home start to wear masks and start to understand that they need to wear them and wear them a little longer every day, because those teachers need to teach. They don't need to be the sort of supervisors of mask wearing.
I think this is a good time for me to let the public know as well that the week of July 20th, we are going to be dedicating the whole week to back to school. We're going to have a lot of experts on, some from the state, and we're going to talk about everything related to teachers and students. So we invite you to join us that week. The reason we're not doing it next week is because we believe that that's when a lot of the school districts around us next week are going to be issuing some of their directives and plans and uploading. And we thought it would be more fair to let them make their decisions, and then we'll answer some questions. So
We could say chalkboard, go back to a simpler time.
I mean,
Yeah.
come on now.
If you're
Yeah.
bad, I'll make you clean the erasers.
Right, yeah. I wonder what they do. Oh, one more teacher question though today. Tracy wants to know, I'm a teacher, should I buy a purifier, an air purifier from my classroom?
Yeah. We haven't been big advocates of that from the cruise ships and from other household and contact tracing. It doesn't seem like really the air itself is going to be a big problem with spreading the disease. The bigger problem is close proximity to people in gatherings. So really the air purifier, it could add some benefit. I don't think it's a must-have or a to-do. Basically what you're going to want to do is continue the distancing, the hand sanitizing, the masks, the cleaning of surfaces, things of that nature. So again, the air purifier won't cause any harm. The benefit is really going to be minimal, but it can be used as an adjunct to all those other measures.
Bob, you have a question?
Yes, Andrea wants to know, I've read that the virus is now more contagious, but not necessarily more lethal. Can you speak to that, please?
Go
Me?
for it.
Okay. I don't know if she's referring, there was a study from the Scripps Institute about a certain, not a mutation, but a substitution of an amino acid in the spike, and the spike is what everybody sees on the picture of the coronavirus. It's what attaches to the receptor in our body, and then that's what causes an infection. It's an interesting point. It's very good. They certainly have looked at various isolates around the world and now think that this isolate is the more dominant form. It was introduced in several places at once. When it was introduced, it has kind of taken over as the dominant form. It's an interesting finding. Again, it is a substitution of one of the amino acids. It looks like it may bind to the receptor a little bit better in the lab setting with pseudotype virus, so not necessarily with SARS-CoV-2, but when they put it into a lab setting, it looks like maybe it has more viral load. They're very interesting findings in the lab. It's one thing to consider, but certainly we don't really understand, we don't believe, and there's no evidence that it is a new strain and it has any biologically different properties. As far as if the virus is less lethal, well, I think as we have gotten further into this, we've seen that different populations have been infected. So initially it was certainly the nursing home vulnerable populations. We've seen the health disparities in other minority populations as well, which in general have had large health disparities. So now what we are seeing, for the most part, are younger people infected. And we've always said that younger people have less probability of having hospitalization and critical illness and death. So that's part of it as well. The other thing is we have been able to better treat people once they have come into the hospital. So we have evolved our treatment modalities. We aren't putting people on the ventilator as soon as possible. We are holding off from putting people on the ventilator. We are using high-dose anticoagulation to treat the blood clots that we know occur in this disease. We have remdesivir, which we're using. We have steroids, which we're using. So we are using all sort of different supportive measures, but also have other drugs that we can use to help fight this disease as well. So there are a lot of different factors to that. We don't believe the virus has otherwise mutated or changed or anything like that. But certainly from that original question, it looks like from that publication there may be a dominant form, but that is not new. SARS-CoV-1 from 2003 had a dominant form that came about as well as Ebola. So this is not new in the world of viruses. But as far as any biologically different or clinically significant strain or virus or mutant, we haven't seen that at this point in time.
Did you want to add?
I don't think so. He's got it.
I know he does. I have a real quick one. Sharon said that her friend's 6-year-old son tested negative after the father, whom he lives with, halftime tested positive. They tested him down the throat, not the nose, and she wanted to know, is that normal for kids, and is that reliable?
Yeah, so certainly the gold standard right now is the NP or the nasopharyngeal. There are other tests, and again, for the most part here, we use the nasopharyngeal because that's what's been validated and that's what our platform is. Occasionally, if somebody can't have a nasopharyngeal, they will use an oropharyngeal. Say if you had sinus surgery recently and it's really delicate in that area. There are other tests that are coming out looking at saliva as well. So it just depends where you're getting your test, what their company or their platform is that you're using. But certainly for the most part right now, the gold standard would be the nasopharyngeal, but there are other ways to obtain a sample.
I don't know if I'm going to go ahead and say this. I recently had the opportunity to have a COVID test. And I want to just say that I was completely terrified and freaked out about it because of the brain biopsy. But I think just like our treatment modalities, we're getting really good at doing those tests too. She told me to put my head all the way back and it went up, whistle slick. Little bit of a twirl that's little tiny bit noticeable, you know, and she pulls it right out. So it wasn't really a big deal.
No, I've had several friends recently this week also who've had it, and they definitely describe it as a brain biopsy. But our nurses here have become so efficient at doing it, causing least amount of pain and discomfort, but getting the adequate sample. So we are getting better at that too.
And obviously mine came back negative, so knock on wood somewhere. Yeah, we're good to go. Bob, you got a question? Oh, did you want to say something?
Well, I just wanted to say that we are moving to a place where many counties are mandating testing for all staff on a routine basis for COVID-19 as part of the recommendations that came down from CMS. And so all of your nursing facilities out there are looking for a non-nasopharyngeal way to do this. Some of them have found labs that will do it. So I just want to let you know that that's coming really regionally, and that should not be a deterrent from really continuing to take care of our frail older adults in that setting.
Yeah, it's a good thing, and it's a good peace of mind too. All right, Bob.
All right. Lorraine says, I love it when Dr. Stites whips out his goggles and demonstrates that for everybody to see.
Yes.
The question is, should the public be wearing goggles all the time, anywhere they go, along with a mask?
Yeah, I would certainly advocate for that. You know, nobody wants to wear a mask. We've said that. I don't want to be wearing a mask. We have to now. This needs to be our culture. The other thing to consider, and certainly I did this on the airplane, is eye protection. Goggles or a face mask. There was a very good opinion piece, I think, in JAMA Internal Medicine or JAMA Open Network by Dan Diekema out at University of Iowa, and they made the case for face shields. You know, face shields are just clear plastic. They look like welders' helmets, but they're clear plastic. You don't have any visual disturbance from that, as well as the mask, and that can also greatly reduce your exposure to the virus if you are in a situation where you can't physically distance, where you can't be outside, where you're in other gatherings. So I think face shields and eye protection should be definitely considered by everybody. Again, we wouldn't consider eyeglasses or sunglasses eye protection in the healthcare setting, but you know, certainly if that's all you had and you had larger sunglasses, say, that may offer a little bit of protection, but you really need the protection on the sides and the top. So that is one thing to consider. I would certainly advocate for that as well.
Can you speak to some people who I've heard advocating for either face masks or face shields?
Very good question, yeah. We do not feel that just the face shield itself would offer that protection. You really need your mucous membranes covered. Mucous membranes are your eyes, your nose, and your mouth. And really the mask covers the majority of that. It covers your nose and your mouth. So just a face shield or eye protection without a mask would be inadequate. And I would, at that point, recommend obviously the face mask before the face shield.
Brooke wants to know, should we still be wiping down groceries?
Yeah, I think, again, so what we have to understand is the virus is out there. And I go through my daily life as the virus is out there. That is not meant to scare anybody. That is just meant to be fact so that I can protect myself and my family. And if you go about thinking like that, you will be able to make the adjustments in your life to protect you and your family as well. So doing those things, obviously we have said before, there is not a lot of evidence to suggest that it's on the fruits and vegetables. It's not on the food that you're eating from takeout, things of that nature. But if you want to take that and have that abundance of caution and want to wipe down your vegetables in a safe manner, obviously we're not, there are certain ways to do it, and the CDC has guidelines on how to wash down your groceries or wipe down your plastic containers or something like that. That's certainly okay to do. Just understand that, there isn't a lot of virus spread from that. More in general is going to be at the grocery stores, maybe touching things that somebody who was ill came by and touched recently, and then you touch your eyes, your nose, your mouth. But certainly if you would like to wipe down or wash down your vegetables in a safe manner or wipe down your containers, that's certainly a reasonable thing to do.
Trey says, a recent New York Times article says that a large group of experts are now concerned that COVID can linger in the air in indoor environments.
Yeah.
Can you address that, please?
Yeah. So we have always been and maintain that it is not airborne. Typical airborne infections that we have basically known are measles and tuberculosis, and I think everybody is familiar with those. Tuberculosis is a bacteria, measles is a virus. There was a position paper by couple hundred scientists sent to the World Health Organization about you need to consider that it's airborne. The World Health Organization has now stated that it could be airborne, but if you read their statement, what we need to understand is that it is not airborne in the fact of, and there is no evidence to support that it is not airborne in the fact of measles or tuberculosis. It can still linger in the air on small droplets, and that is consistent with what we have been said. If you look at other evidence, and again, we don't have a lot, and as we move forward, we'll learn more, and we will adjust our knowledge base and our thinking. But from when they looked at areas and wards where COVID patients were treated, even with physicians or providers who were not doing aerosol generating procedures and who just had face mask on and eye covering, there was no spread of the disease to those people. So typically for airborne illnesses, you need an N95 or a PAPR mask, which is a big hood with an air generator on the back of it. The other thing is when they did do air sampling in areas where they treated COVID patients, they did find that they could detect the virus, but they weren't able to culture any of that virus. So I think that has to do with decreased concentrations in the air. Most of the droplets, most of them are going to fall down onto the ground because they will be heavier. Certainly some could linger in the air, but then you're decreasing the concentration enough. The other thing we have is from the household contacts. We understand that household contact rate, if somebody has it and spreads it to their household, is typically around maybe 5 to 30%, depending on what research article you're looking at, but on average about 15%. You would expect if something were airborne and people were in close proximity, such as a household together, that attack rate would be up to 70, 80, 90%. The other thing also, they certainly ruled out things like the AC or the air conditioning system when they looked at the infections that occurred, say, on the cruise ship where you have those confined spots. So, again, the best evidence we have is that it is not airborne. There could still be small aerosolized droplets that may linger in the air, but the most way that this is spread is by close contact for a certain amount of time and in large gatherings. Also with fomites or inanimate objects as well. So that's kind of the best evidence that we have against necessarily the traditional airborne sense of infection, in the sense that we think of measles and tuberculosis.
Paige wants to know, how soon can you return to work after a positive test? What are we telling the people in the nursing homes?
So, you know, the CDC recommendations that are out there would say, at least the last time I reviewed them, would say 10 days after that positive test. There are some companies that are choosing to extend that a little bit farther out just because that population is so vulnerable. But the data that's out there really suggests that 10 days after a positive test, if the person was asymptomatic, or 10 days after the symptoms began, is a time that the viral load is low enough such that they can return to work. Returning to work continues to mean wearing a mask, wearing eye protection, and doing all of the same things that they have been doing and should continue to do.
Yeah, absolutely.
Good advice in an office?
Yeah, absolutely. We, again, would obviously advocate for face mask wearing in an office, because you never know if you're going to be around other people. They could just walk up to you and you guys could have a conversation. Also, you know, again, eye protection is not unreasonable if you felt you want to do that. Certainly in the hospital, we are wearing eye protection with any patient encounter. And once the eye protection is on, when I'm starting to do my rounds, it pretty much stays on all day. So that's good. But to your point, yeah, the best evidence that we have as far as culturable virus from the upper respiratory tract, it really seems to be in lowest concentrations and really not to be cultured or known to show infectious virus, probably at around 8 to 10 days after symptom onset. And again, that's for mild to moderate disease in patients who are hospitalized. So as we move forward, we'll certainly learn more. It's very hard to do these types of viral studies because you need certain precautions in certain labs to culture the virus. But it's based on those small studies and also other indirect evidence such as contact tracing and things of that nature.
Sean wants to know what your thoughts are on the Regeneron antiviral cocktail now entering the third phase.
Yeah.
So-
Yeah, I mean, again, I think that as we move forward, we definitely need direct acting antivirals, something like Tamiflu that we have for influenza, something like acyclovir that we have for HSV infection and other viral infections. The other things that we are using is convalescent plasma, and we're also looking at using other things to decrease the immune system. The Regeneron is going to be one more adjunct to this cocktail or this treatment regimen that we're able to give people once they get ill with COVID-19. And also it's going to matter about the timing that we give these drugs. So I think it's probably promising. We have other evidence that these types of medications, these antibodies are helpful in other situations as well. So I'm certainly optimistic that this will be one more thing that we can use to help decrease hospitalizations, critical illness, and death.
Bob?
Jean says, we've been talking a lot about how to keep kids and teachers safe in the classroom. How would you deal with school buses full of children? My granddaughter takes the bus to school.
Yeah,
That's a great question.
great question.
So I think as we move forward into the school year, everything is going to get creative.
Yep.
And some of that creativity may mean having half full buses. And that may be, you know, different school districts I think are going to do this differently. It can be partially helped if they go to some of these half classroom sizes, but there are a lot of downstream things to consider for every decision that we make. The key continues to be masks, hand hygiene, and if they can be distanced, to be distanced, and most, and very importantly, if your kid is sick, they need to stay home.
I agree completely. I think in those cases, it will be technically in the prolonged for the most part, which is a 10 to 15 minute exposure and close proximity to each other. I think mask wearing will be vitally important, as will education about hand sanitizer, and maybe kids bringing their own hand sanitizer on the bus and using that frequently. So I think as we move further into this, we will have those types of recommendations made by each school district and each school that is having the buses, but masks are going to be vitally important for this, because these are a vitally important way for children to get to school on a daily basis.
Bob, we have time for about 2 more questions.
All right. Embalia asks, If you're with your spouse, how long should you both continue to wear your mask after returning from the store or restaurant where people were not wearing a mask? Should you continue during the whole car ride home, or can you remove them once you're in the car?
Well, I would, if I had, and I carry alcohol spray in my car, I try to remove that once I get into my car. I think you can do that. If you can do that safely with hand hygiene prior to removing the mask and hand hygiene after removing the mask, I think that's the best time. Once you get out into the open air or into the safety of your car, I think that's an appropriate time to remove the mask.
Yeah, I'm not sure there would be much benefit to continuing to wear it.
Right.
In fact, probably taking it off more quickly if there was perhaps an exposure when you're in a safe place might actually be more helpful.
You drop it on the floorboard,
Yeah, absolutely.
put it on a trash can?
You know, I mean, if you think there's an exposure, I mean, you know, we've always advocated for, most people have the cotton mask, so we've advocated for having 3 or 4 of those, so one that could be used, one that could be stored, one that could be cleaning, and you can rotate those. So if you have a cotton mask, you can obviously just drop it on the floorboard and pick a new one up when you get home. But again, remember, the hand hygiene prior to removing it and after removing it is going to be important as well.
Bob, another question?
Jennifer says, if a person gets a test because someone they were with tested positive a few days prior, and your test is negative, is this accurate? Because the symptoms can take up to 14 days. So can it be too early to take a test in some instances?
Yeah, absolutely. We do not advocate for testing just because you are a contact of a person. This has to do with you may not be developing symptoms yet. You may not have evidence of infection yet after exposure. That can depend on the amount of viral load and the time that you're with that person. In addition, that test is only good for, say, 1, maybe 2 days after that test at the most. And we still know that there can be an incubation period of 14 days. Although most people will develop symptoms, most people who do develop symptoms will develop symptoms at 5 to 7 days after exposure. The other issue to that now is we are really running into a testing capacity crunch. So testing capacity is number one, enough swabs, enough media, and enough reagents to actually do the test in the lab, in addition to just really enough time to get all the tests done during the day. We also want a quick turnaround time. So I just said that the test is in general good for that day or maybe 1, possibly 2 days after. We use certainly 48 hours for pre-op testing. But after that, it really is an invalid result. So unfortunately, I think now testing results are coming back at some of our labs around the city or some private labs 3, 5, 7 days after they're obtained. And at that point, those results are no longer valid anyway. So we still advocate and recommend that if you are a contact of a known case, don't get tested unless you have symptoms. And even if you get tested and it's negative, you need to continue to wait out that 14-day quarantine.
All right. I think we're going to wrap it up for this morning. We really appreciate you being with us. Final thoughts from you, Dr. Calendar-Rich.
I just want to thank everybody for everything that they are doing out there. We are all, it's amazing. I'm seeing more people wearing masks, more people really being careful, and I just think that I'm appreciative that it seems like we are all getting the message and we can continue to move forward together.
How do you want to send us off into the weekend?
Yeah, I know several people, I know several families with young kids, middle-aged, high school kids. A lot of those families are in quarantine now. It is certainly spreading through the younger populations, but it's also spreading through the young adult populations, 20s to 30s, who are continuing to go out, not practice the pillars of public health guidance that we've talked about, the social distancing. Please, be doing things outside if you're going to meet in groups. Don't meet in large groups. And if you are, make sure you are physically distancing. I know we say 6 feet. I try 8 to 10 feet, especially if you're outdoors. That's very doable. Wear your mask. Bring your hand sanitizer. Use alcohol gel frequently. If we can do those things moving forward, we are going to hopefully bend that curve again, flatten that curve, so that we don't have a continued increase in the hospitalizations from the spread of COVID in our community.
People listening and watching really do have the power.
Yep.
They do, and we appreciate you. Let me tell you what's coming up next week. We want to give you a peek. We're going to update lab testing. That's on Monday. We're also going to, on Tuesday, you're going to want to be with us because we're going to hear from a COVID-19 survivor. This is a man who has 9 children. He was very, very sick when he came to us. He got it in rural Kansas, and he's going to come and share his story. We're also going to talk about travel bans next week, how to predict them. If you've got some last-minute travel you're going to do before school starts, we're going to give you some insight on how to watch those states and know where the hot spots are. And on Thursday, we're going to have the chancellor back from KU. Dr. Doug Girard is going to join us and talk about how things are going on campus over in Lawrence. All right, can I just tell you how much I appreciate you? And here's what really warms my heart. Every time one of you sends us a picture of how you are keeping others safe and how you're saving a life. I want to give kudos to Jimmy from Olathe South. We know that his favorite team is the Chiefs. Do we have Jimmy? Nope, we don't have Jimmy. Okay, Jimmy, we'll get you next week. We have Maurice, you're rocking it with your pink and your gray and saving a life, way to go. And do we have Tiffany? Nope. All right, folks, I think we've had a little bit of, we'll go ahead and let's cycle through these pictures and we'll get the names for you again on Monday. I think we might have had a little bit of a communication gap with the team, but that's all right. We love seeing these pictures, love the Royals. We're an equal opportunity sports team and fans here in the studio, so we appreciate that. All right, so please continue to send us your photos of your mask wearing and your social distancing. You can send it to the Facebook or email us at medicalnewsnetwork@kumc.edu. And we also want you to share your stories. We talk a lot about numbers, and we would love to be putting some faces with these stories that we are hearing. So until Monday, have a safe weekend. Dr. Stites will be back in the proper spot along with Dr. Hawkinson, and then we'll have Rachel Leesman to talk about lab testing. Make it a great weekend, everyone.